Hey guys, it's Joel, and I wanted to do a quick video. A lot of people on here will make mention about how I talk about different styles of therapy and how they fit together, or kind of different approaches in the school of thought they fall into. Now, keep in mind, like a lot of these schools of thought are not actually happening during the same time or from a school or body of people who know each other. Just sometimes people conceptualize psychology and psychotherapy in ways that are similar. And so I wanted to do like a quick video that kind of shows the way that I think about all the approaches of like psychotherapy that I've read about, and kind of how they think I work, or they work together, because that is something that a lot of people tend to ask about. So basically, I think about the way that these work along two axes, and one axis is analytical versus experiential therapies. So analytical is an approach where the therapist is conceptualizing or helping you conceptualize everything that's going on. So there's a lot of models, there's a lot of psychoeducation, there's a lot of interpretation that the therapist is doing. That this represents that, and you see what you're doing, and compensation is here. And then the opposite of that would be an experiential model. In an experiential model, the therapist isn't telling you what anything means. They're pushing you into an experience, and then you're having that experience. Exposure therapy is very much like that. The way that David Grand talks about brain spotting and the way that it should be practiced is very much an experiential model. He says that the brain is smarter. The deep brain is very intelligent and wants to heal, which is almost kind of a shamanic idea you see in a lot of tribal cultures, and that when you go into that place, the brain is healing itself. The therapist is just opening it up. Anything that they say is going to get in the way a lot of the time. Anything that's suggested is not going to be as smart as what the patient's deep brain can just come up with. So in brain spotting training, they say a whole lot: turn off your brilliance, turn off your brilliance. Just let the patient be. The other two axes that I think about these models of therapy on, one of them is like very ego-driven, kind of obsessed with the thinky part of the brain. So that would be over here. Like ego, cognitive behavioral therapy, cognitive therapy, it's all about like what you can control, what you can think, what the ideas you can come up with. The opposite of that would be therapies that are more trauma informed. They're going to be targeting the subcortical and emotional brain. And those are not often as concerned with like what we know intellectually, but what we feel in a deep way, especially what we're able to experience in our bodies. And this is important because you need some ego management stuff to be able to get through the day. But also, if you're going to be treating trauma, it doesn't matter what you know. You can understand why you smoked cigarettes and talk about what mom did that makes you smoke cigarettes for 50 years in psychoanalysis, and you still smoke cigarettes. You're not really going back into that place. Something that's more Jungian, or something that is more about experiencing your physical and emotional reality, that's going to take you back into the trauma, because the trauma is not here. It's not in the prefrontal cortex, a deep brain, or at least it doesn't start here. It's in this kind of body brain that's this deep emotional system of how much energy do I respond to the life with, how much, what is my reaction to being confronted, what is my reaction to having an emotional need, is it a fear that it's not going to get met immediately? And all that's happening here in the body before it kind of comes up and colors your cognition. So simply thinking about it and analyzing it doesn't really help you get that emotional, defensive response out. A lot of the things that we inherit about how we handle emotion, I think, are genetic. Some of them, something like the obesity study during the Siege of Dresden shows you that what the mother is feeling when the child is in utero is extremely important. If you're not familiar, what they did during that study is there were children that had been in first world, their mothers had been in first world living standards their whole life, and then they're during Siege of Dresden, they're starving while they're pregnant, but the children were back in first world standards of living by the time they're born. They never actually knew hunger. Yet all of them, by the time that they're middle-aged, are obese, because there's some sort of physiological response that's turned on to prepare them for the world that they're coming into, even when they're in utero, that says, hey, there's not enough, you've got to go, you've got to do this. Again, that's not an intellectual cognitive idea that they learned because they saw something and started to retain it in memory. It's more of that body-brain response. So I'll go ahead and jump into this, and then again, remember, all of these models can be practiced a bunch of different ways. There's people who I know in Birmingham who are great therapists that say, I do CBT therapy, that's what I'm trained in. But you sit down and you talk with them about how they conceptualize stuff, or you do a consultation group, and they're doing attachment work and psychodynamic things and, observational psychology. A lot of the times, even though it's maybe in the framework of CBT and has that language, they're doing other stuff. So none of this fits, perfectly into one category. And a lot of people are out there like me, where they mix and match everything and they kind of find their own style. So this is just kind of broad strokes. Again, how these are practiced or how you interpret certain things in the manuals maybe pushes the dot a little bit in a different spot. But overall, I think this is fairly accurate. If you disagree, leave a comment, and I'll go ahead and jump in and look at the model.
Okay, so I've got my little piece of paper. So here you have at the top the analytical or conceptual, which is a therapist being very interpretive. Down here is the experiential model, where the patient is just sort of pushed into an experience. On this side of the spectrum, you have cognitive and ego-driven, managed cognitive therapies that are prefrontal cortex. Here you have subcortical or depth modalities that are more concerned with the unconscious mind and the deep body brain. So what you tend to get up at this top, styles that are going to be very analytical and also very conceptual, are going to be things like this, like solution-focused brief treatment. These styles that got really popular in the 90s, where everything that was pushed forward had brief or solution-driven or time limited in front of the model that got pushed out. There's too many of those really to list, and I'm not really interested in those modes of therapy. I think that they were mainly driven by research pushed by insurance companies that wanted people to get better faster, but what it ended up doing was creating a lot of band-aids. So that didn't get to the root of the issue. So solution-focused brief treatment, where somebody comes in and you ask them the miracle question, which is a big idea in that modality. You just say, hey, you snap your hands together and everything's better. What does that look like? And then somebody says, well, I would do this, this, and this. And you say, okay, well, this is how you do it to get there. Well, I mean, that doesn't really rely on the patient getting to know their deep self very much. Most people don't come into therapy knowing exactly what they want or what they need. But solution-focused brief treatment is very analytical, it's very ego-driven, it's very cognitive, it doesn't care. You also have REBT, which is very similar to CBT in my mind, other than it had a charismatic salesman that invented it, and so it was different, but pretty similar. Cognitive behavioral therapy is maybe a little bit more open. You have this idea in cognitive behavioral therapy that you're going to get to the core underlying belief that Beck says is the hardest thing to change. Yet those beliefs, even when you get down to what cognitive behavioral therapy considers the root of behavior, they're not very deep into the subcortical brain. They're these kind of fundamental beliefs, but those beliefs a lot of times don't go terribly deep into like attachment, physical realities, and emotional realities. They're beliefs. He thinks they're kind of cognitive ideas that you're carrying around in your mind and that you need to get rid of. I think Freud and Yalom are very much over here. I mean, something like existential therapy. I don't even think I put that on here, but something like existential therapy is going to be here. When you read Freud and Yalom, you can get the sense that they're brilliant, except they're very much in their head. Yalom even says something in one of his books about how he went to a therapist that was supposed to help him relax by using muscle relaxation, whatever, and he hates it and doesn't ever go back. He doesn't really talk about the deep body brain, the subcortical depth effect of trauma very much. He's not interested in that. He's kind of more like people need to get in their head and hash things out for a really long time, and eventually all of that thinking will just kind of result in the feeling being exhausted over this long course of treatment, which, again, isn't wrong. None of these are better or worse. So like down here, you have something like coherence therapy, which is sort of almost a parts-based psychoanalytical thing. I like it because it's more experiential than psychodynamic and psychoanalytical styles, but it's also not super popular. You have something like ego therapy, Anna Freud's thing, and then I don't know the name of the people that do the modern versions of that. EMDR is very experiential. I mean, you're setting somebody up with a thought and then you're letting them have an experience that is, pretty subcortical, pretty depth. It's also an experiential style, but you're still thinking. With EMDR a lot of the time, and I get flack for this every time I say it, somebody will leave a comment, I know that there's a somatic, modality. I know that there is a somatic protocol for doing EMDR, but you're starting in the body, you're starting down here, and then you're immediately jerking them back up into the ego because they're thinking. So it's, yeah, I feel my back, I feel this, I feel that. All right, now, oh my gosh, I'm realizing this. It wasn't my fault. I was 8 years old. You're having these realizations, and you're asking them what they think, and you're kind of starting down here and then pulling them back up there. So it's a hard one to face. Something like emotion focus therapy, even though, the word emotion is in there, I still think is, you're still getting people to kind of talk about that effect on other people. Emotion focus therapy, most of the studies are done on couples or groups of people that are kind of in the room together. So you still need the communication piece. It's definitely very experiential. And maybe it should be a little bit further down there. You get something that is developed from the Jungian techniques, like internal family systems or voice dialogue, which are really pretty similar styles of therapy. And they're very experiential in that you're forcing, like voice dialogue, they even do sort of like chair work, where they make you switch from one chair to other and then become the other part of your personality and talk from it, and then you're shocked by what it's saying, and you have to deal with that part of yourself. That kind of psychotheater, psychodrama stuff that Gestalt therapy and Fritz Perls used. Internal family systems, Schwartz says in all of his things that you're not supposed to conceptualize at all. You're not supposed to say, well, I think that there's a part of you that's afraid of being judged, and that part of you is creating another piece that judges everybody, and you kind of need to bring those close together. That he would not like that. He wants you to just push the patient into that piece and then have them experience everything that they go through in that area. AEDP is similar to like sensory motor and somatic. It has more of an attachment part. It's interesting. I think it's very experiential. I also think it's pretty subcortical in depth. You get Gestalt therapy where Fritz Perls says that the therapist is not really supposed to do anything except push the patient into having an experience. So somebody comes in and they say that they're depressed, and you're like, yeah, feel the depression. Yeah, go there. Get as depressed as you can. Where do you feel that in your body? Just go into it. Oh, it's the blackest place ever. I feel like I'm going to die and my dog's going to die and everyone's going to be sad. Okay, feel the sadness. Just go there. And through pushing them into that very deep subcortical thing, they kind of start to realize they can survive that area, and they start to have a new idea and heal. But you're not analyzing at all. You're not trying to get there through analysis. Brain spotting, I think, is extremely experiential and depth-based. When brain spotting's working, you're not thinking at all. It's not like EMDR where you're realizing things. You are in a place that is beneath language. You are having this deep emotional experience, this deep body experience. And one of the things that's very common is that when people come back out of that, they almost can't fit what they know into words. It's not an intellectual knowledge, but yet they know a new thing emotionally. So, when you kind of go up to psychoanalytic or Jungian styles, these are some of the old styles. Freud obviously started psychoanalytic therapy. Jung obviously started Jungian analysis or depth analysis, depth psychology. I think psychoanalytic is almost more experiential. A lot of Jungians made more experiential modalities later. James Hollis, what's his name? James Hillman did a lot of things where he was encouraging people to find the somatic relationship to the archetype and to feel the warrior, personally or something. But Jung himself was pretty analytical. He's talking about very subcortical, depth-based ideas. He wants them to kind of feel this deep, unconscious, intuitive world, but he wasn't really pushing them to experience a ton. And I'm sure that there's a lot of exceptions to that because Jung just did so much, but it usually is focused on understanding things. Things like word association tests or sand tray or Myers, I know that Jung didn't do the Myers-Briggs, but Jung did the original kind of introversion, extroversion, modes of thinking that he thought about as radio waves that led to that. And all of those things are still about understanding something. They're about the therapist having the knowledge. This is top down. The therapist is the expert. The therapist is helping you figure this stuff out. And these are the patient is learning. The patient is figuring this stuff out. Transactional analysis, I don't want to skip it, but it's a kind of very fatty, I didn't say fat, I said fad, like it's a fad. that comes about and flares in popularity and then disappears. But it's basically kind of a repackaging of psychoanalytic therapy, but it's making it a lot more it's making it have more of a formula, which was a big trend at the time. It's less up to what the psychoanalyst wants to dream up from their own creativity and more, a formula about how you're supposed to analyze patients. So, you need all of these approaches as a therapist. You need to be aware of all these worlds. If you're just telling people everything that you know, even if you're right, they're not ever really going to be able to soak it up. You have to push them into experiencing how some of this stuff feels. Yalom has something in Existential Psychotherapy. He cites a study where he says that people who have more of an authority fixation prefer therapists that are passive, that don't talk as much, that probably are more experiential, because they want to just be able to talk and control the session, whereas people who are more wanting to look up to authority, they have a little bit more of a passive fixation. They want an analytical therapist who is going to tell them everything that they need to do. The danger here is that you're prescribing everything and you're not leaving anything up to the patient. Here, this is a place, the risk of this is something like maybe when they do the ketamine infusions with no guide or no psychoeducation or no knowledge about trauma. I've seen that really damage people because you're just turning on all of this decompartmentalized stuff and then you're not giving them any tools to deal with it or how to integrate it. I would say that's too experiential, right? Be it a doctor or not, just giving somebody a drug trip with no information about trauma and no training in how to treat it. The cognitive and the ego stuff, this is prescriptive therapy. So these are kind of ego management strategies. You're saying eat 3 meals a day, go to church, lift weights for anxiety. You're telling the person what to do. The subcortical depth stuff is more personal. They're having to feel what it is that they want to do that makes them kind of unique. And I think that you need a range of those too. I mean, if you just jump into Jungian analysis with somebody who comes in and they're trying not to bite their nails, I don't know that that's going to, and I love Jung, but I don't know that that's going to get you anywhere. I think that you need to start a little bit more concrete than that. So I don't know. I hope that's interesting. If y'all have any questions, leave a comment, and hope that is a helpful way to think about a lot of these modes of therapy.